You know, usually when we talk about a medical diagnosis, there's this underlying expectation of precision, right?
Absolutely.
That
Yeah.
feels almost like an engineering problem. Like you break your arm, you go to a sterile room, the X-ray machine hums, and there's that jagged white line on a glowing screen.
Right. And the doctor just points at it and says, there it is. That's the problem.
Exactly. It's binary. Broken or not broken. It's clean, it's categorized, and honestly, it's kind of comforting.
Because it's physically visible. And we've built, our entire understanding of modern medicine around that specific type of visibility.
Yeah, but then you step into the world of global health, and specifically into the middle of a humanitarian crisis.
Which changes everything.
It really does. Suddenly that metaphorical X-ray machine is it's shattered. There's no power grid, there's no hospital.
No infrastructure at all, usually.
Right, and that jagged line you're looking for isn't a broken bone, it's a deadly pathogen, just moving silently through a camp of, 500,000 displaced people.
Which is pretty much the absolute definition of diagnostic muddy waters.
Yeah.
You are completely blind unless you know exactly how to look.
Right.
And knowing how to look when the entire surrounding infrastructure has collapsed is just an entirely different scientific discipline.
And that is exactly what we are decoding today. We are taking a deep dive into this invisible web of disease surveillance.
It's a fascinating topic.
It really is. So for you listening, we've got this dense, intense set of academic research and field protocols on reporting, surveillance systems, and record keeping in conflict zones and global emergencies.
Yeah, the source material is quite extensive.
It's a lot. But our mission today is to figure out the actual mechanics of how this works. Like, how do we track an outbreak in a place with no roads?
Right.
And how do the people on the ground keep a localized emergency from spiraling into a global catastrophe?
Well, it is a massive logistical puzzle.
Yeah.
And while it might be tempting to look at the source material and see, a lot of dry statistics and bureaucratic flowcharts.
Lots of acronyms.
So many acronyms. But it's crucial to ground ourselves in what we are actually analyzing here. For vulnerable populations, these data points are literal lifelines.
Wow. Literal lifelines.
Yeah, because a well-placed piece of information in a refugee camp is really the only difference between containment and a devastating epidemic.
Okay, let's unpack this. Because to understand the sheer chaos of a crisis zone, I feel like we first have to understand what the ideal system looks like.
That's a good place to start.
And the foundational concept in the research is something called epidemic intelligence, which, I have to admit, sounds like the title of a geopolitical thriller.
It does sound like a movie, yeah. But it's actually the anatomy of a public health warning system. The terminology is dramatic, but it really fits.
So how do the sources define it?
They define public health surveillance as the systematic collection, analysis, and interpretation of health-related data. And the keyword there is systematic.
Systematic, meaning not just a one-off thing.
Exactly. It is not a one-time survey where you parachute in, count the sick people, and leave. It is a relentless, continuous loop.
Right. And the research maps out this loop as the epidemic intelligence continuous cycle. It's this 8-step machine.
Yeah, it goes input, process, detect, verify, respond, report, risk assess, and analyze.
And then it just feeds right back into itself.
Constantly. Think of each step as a specialized filter. If we look at the input phase, you're constantly pulling information from every conceivable direction.
Like where? Where does it come from?
Well, you have data coming from national health systems, from laboratories, from humanitarian workers out in the field,
Right.
and even from community surveillance, where local leaders are just reporting unusual events in their neighborhoods. But raw data is inherently messy. It is full of static.
Which means you have to process it. The documentation talks about deduplicating and geotagging.
Yes, deduplication is huge.
Meaning ensuring you aren't counting the exact same sick patient 3 times just because they visited, 3 different aid tents in one afternoon.
Exactly. And then figuring out exactly where they are on a map with geotagging. Once you clean that data, you move to detect.
Which is where the human expertise comes in, right?
Yeah, this is where you are staring at this cleaned up data, actively hunting for signals. If there are suddenly, say, 50 cases of severe acute respiratory distress in one specific isolated quadrant of a camp,
That was a signal.
it's an anomaly. It tells you something is wrong.
It makes me think of a weather radar, but for human biology. You wouldn't wait for a Category 5 hurricane to literally rip the roof off your house before you acknowledge it's raining.
No, you wouldn't.
You want the early warning system. You want to see the storm forming out over the ocean while you still have time to board up the windows.
That is a very accurate way to visualize the objective, actually. But what is highly emphasized in the source material is the very next step in the cycle.
The verify step.
Yes, the documentation explicitly flags this as a non-negotiable step to rule out errors. You have to use lab confirmation, consult credible secondary sources, or send a team to do physical field verification.
Meaning you cannot just blindly act on a blip on the radar.
You absolutely cannot.
But hold on, that feels counterintuitive to me. If I see a massive storm forming on the radar, shouldn't I sound the alarm immediately? Why hesitate?
It's a natural reaction to want to act fast.
Right, especially if you are in a fragile setting with hundreds of thousands of vulnerable people. Isn't speed more important than waiting for a lab result?
It seems like it would be, but in a fragile public health context, acting aggressively on unverified data can actually be as destructive as the disease itself.
Wait, really? How?
Let's put you in the shoes of a decision maker for a moment. Imagine you are running a displaced persons camp, and you receive an unverified, terrifying report of a highly contagious hemorrhagic fever.
Like Ebola.
Yeah, Ebola, for example.
Okay, well, my immediate reaction is to lock everything down, quarantine the sector, shut the gates, call for international hazmat teams.
Right. And if you do that without verifying, you trigger absolute panic. People might flee the camp to avoid the lockdown, potentially carrying the actual disease if it exists out into the surrounding country.
Oh, wow. I didn't think about that.
Or they flee into the wilderness and die of exposure or other diseases. You have just diverted massively scarce medical resources. You've disrupted the vital supply chains, bringing in food and clean water.
It's just absolute chaos.
And you've terrified a population that has already been through severe trauma.
Okay, I see the domino effect now.
Yeah, and if it turns out that the initial report was just a data entry error or a rumor sparked by someone with a severe but non-contagious illness.
You have manufactured a secondary humanitarian crisis entirely by accident.
Exactly. You basically burned the village to save it from a fire that didn't even exist.
That completely reframes the verify step for me. It's not about bureaucratic red tape.
Not at all.
It's about preventing self-inflicted wounds. And I guess that's why risk assess and analyze, which the texts describe as data modeling and characterizing the actual hazard, are built into the loop before you trigger a massive policy shift.
You have to know the storm is real, and you have to know its exact trajectory before you react. And the texts differentiate between two main methodologies for gathering this data in the first place.
Comprehensive and sentinel surveillance, right?
Yes. Comprehensive implies drawing data from the entire population, constantly monitoring reports from all labs, clinics, and healthcare professionals.
That sounds like the ideal scenario.
It is the gold standard for calculating exact, granular rates of disease across a whole country.
But comprehensive surveillance requires an environment where things actually work. Like, you need a robust national healthcare system, digitized records, reliable power.
Which is very rare in a crisis.
Right. So sentinel surveillance feels much more targeted. The notes define it as using a selective network. You pick a few key high-traffic hospitals or clinics, and you monitor them incredibly closely.
You are intentionally sampling the population. If a severe flu outbreak hits those specific sentinel sites, you extrapolate the data.
So you guess the broader impact.
Mathematically, yes. You assume that if it's hitting these 4 clinics at a rate of 20%, it's likely hitting the wider, unmonitored population at a similar rate.
That makes sense. It gives you a highly accurate trend line without needing to test every single citizen.
Exactly.
But both of those systems, comprehensive and sentinel, they still require strict protocols, functioning labs, and a baseline of societal stability.
They do.
So what happens when you take that beautiful, clean, 8-step continuous loop and drop it into a war zone? Or an area that just suffered a massive earthquake where a refugee camp of 100,000 people has literally popped up overnight?
The cycle essentially shatters. It just breaks down. The documentation transitions into the brutal, chaotic realities of data collection in conflict and refugee settings.
Because the resources just aren't there.
The very first hurdle is the sheer lack of resources. There simply are no functioning laboratories to execute that vital verify step we just discussed.
And there's a really tragic point the text makes about historical baselines, because refugees and displaced people often only receive what they call incidental or sporadic health care.
Meaning they only see a doctor when it is a catastrophic life or death emergency.
Right. So long-term medical records practically don't exist. You have no idea what their normal health status was before the crisis started.
Which means you are starting your data collection from absolute zero. You're in the dark. Furthermore, the notes highlight a dangerous tunnel vision that occurs in these settings.
Tunnel vision. How so?
Well, refugee data collection almost exclusively focuses on infectious diseases, which logically makes sense. Infectious diseases like cholera or measles cause explosive, immediate outbreaks that can decimate a camp in days.
Sure, they are the immediate threat.
But that intense focus means non-communicable diseases, diabetes, chronic kidney disease, hypertension, cancer. They are entirely missed by the surveillance net.
So you have people dying of insulin rationing or untreated heart conditions, but because those deaths don't trigger a contagious alert, they aren't generating signals on the epidemic radar.
No, they become statistical ghosts. The system simply isn't looking for them.
That is heartbreaking.
It is. But the friction goes even deeper than what we choose to look for. It's about who is doing the looking.
Okay, I want to push back on this a little, or at least ask a question that I think a lot of people listening might be wondering.
Sure, go ahead.
If there is a massive crisis, say a sudden displacement of people across a border, you instantly see international NGOs flood the zone.
Right, you do.
The Red Cross, Doctors Without Borders, various UN agencies. If you have all these well-funded, highly expert organizations on the ground, shouldn't they have the absolute best, most unified data systems in the world?
It is a very logical assumption. You'd expect a unified front. But the reality on the ground is something the source material refers to as the fragmentation of sources.
Fragmentation of sources.
Yes. You have dozens of well-meaning, highly capable organizations operating simultaneously, but they are frequently operating in absolute silos.
What does that actually look like in practice, like on the ground?
It looks like organizational chaos. NGO A might be using a proprietary cloud-based iPad app to log patient data.
Okay.
But NGO B, operating right next door, might be using paper ledgers because they don't have tablets. And NGO C is using a local dialect for medical terminology, while NGO A uses standard English coding.
Oh man, what a mess.
It gets worse. NGO A might classify a child as severely malnourished based on one specific metric, while NGO B uses a slightly different metric for the same classification.
So they are all vigorously collecting data, but the databases fundamentally cannot talk to each other.
The data becomes completely disjointed. When a central coordinator tries to merge all these databases to see the big picture, they are literally comparing apples to oranges.
That has to skew the numbers.
It does. And worse, they are often double counting. A mother might take her sick child to the UN tent in the morning, the Red Cross tent in the afternoon, and a local field clinic at night.
Oh, I see.
That one child just registered as 3 separate disease cases in 3 different siloed systems.
That completely artificially inflates the outbreak numbers.
This is exactly why the notes are so adamant that standardized case definitions and universally agreed upon protocols are non-negotiable. If you don't enforce a standard language for the data from day one, the information you collect isn't intelligence, it's just noise.
And that is all before we even factor in the physical dangers mentioned in the text.
Right, the environment itself.
You have limited communication networks. You can't geotag a case of measles if the cell towers are bombed out.
Exactly.
You have potential physical threats to staff safety. You cannot send a community health worker to do house-to-house surveys if there is active gunfire in the streets or if the terrain is flooded. The fog of war isn't just a poetic metaphor here. It is a literal physical barrier to epidemiology.
Which forces public health officials into a corner. They have to make incredibly difficult scientific compromises. When the perfect, comprehensive system is physically impossible, you have to build a blueprint for survival.
You have to create a system that cuts through the chaos.
Yes.
And that brings us to the methodology of setting up a simple system in an emergency. The golden rule, straight from the text, is this. Method should prioritize being rapid and practical over absolute accuracy.
I want us to really linger on that concept.
Yeah.
Because it violates almost everything we are taught about science.
Right. In normal scientific endeavors, absolute accuracy is the ultimate goal.
But in a humanitarian crisis, time is the enemy. If you wait for absolute accuracy, if you wait for the perfect lab results to come back, thousands of people might die.
So you just need a direction to point the resources.
You need a good enough answer right now, today, so you can start deploying those resources.
So if we accept that we can't look for everything and we can't be perfectly accurate, what exactly are we looking for?
Well, The notes give us a very specific checklist of diseases to prioritize.
We are looking for conditions that are highly infectious with massive outbreak potential, right?
Yes, diseases that have a short incubation period like cholera or influenza, things that are difficult to treat in a camp setting or they cause severe illness that might require immediate quarantine.
You are essentially looking for the sparks that can burn down the entire forest.
That's a great way to put it.
Right.
But to know how fast that fire is going to spread, you need context. You need demographic data.
Right.
The text emphasizes that population estimates are crucial, particularly categorizing people by age and sex. And there is one demographic that is prioritized above all others.
Children under 5 years old.
Yes, the demographic breakdown specifically requests data separated into under 5s, 5 to 14, 15 to 59, and over 60.
Why the intense, specific focus on the under 5s? I mean, obviously children are vulnerable, but epidemiologically, why are they the anchor point?
To use a different analogy, think of an infant's developing immune system like an unpatched operating system.
Yeah.
It hasn't encountered these viruses or bacteria before. It doesn't have the defensive updates. Children under 5 are the most biologically susceptible to infectious diseases, to malnutrition, and to extreme environmental exposure.
So they catch the metaphorical malware first.
Exactly. They're the first to show symptoms when an environment degrades. Their mortality and morbidity rates are the most highly sensitive indicators of a population's overall health trajectory.
So if the under 5 mortality rate begins to spike,
It tells you immediately that your entire public health system, your water sanitation, your food distribution, your shelter is fundamentally failing.
man, that is grim. But it makes sense. The sources actually included a copy of an MSF Doctors Without Borders Rapid Health Assessment Questionnaire.
Yes, meant for a community sample survey.
And reading this was a massive aha moment for me. I'm looking at it expecting complex, heavily jargonized medical diagnostic questions. But it's asking things like, number of blankets in the house, number of jerry cans in the house, does the house protect against the rain?
It seems so basic, doesn't it?
It does. I just marveled at the specificity of this. How does counting jerry cans act as a vital metric for public health?
It is brilliant in its sheer pragmatism. A jerry can means the ability to safely store water.
Oh, right.
If a family has 0 jerry cans, they cannot store clean water in their shelter, which means they are forced to drink directly from potentially contaminated communal sources daily.
And if that communal source has cholera,
Then the epidemiologist knows that a cholera outbreak in that specific sector isn't just a possibility, it is a mathematical inevitability.
that is wild. And the blankets, let me guess, exposure.
Exactly. Blankets and rain protection correlate directly to respiratory tract infections and hypothermia.
Right.
You do not need a sophisticated laboratory test to predict a massive spike in pneumonia if you surveyed a camp and find that 80% of the population has no roof and no thermal protection.
The questionnaire predicts the disease before the pathogen even takes hold.
Precisely.
It also asks for nutritional info. Specifically, it mentions weight for height and something called MUAC. MUAC.
MUAC. That stands for mid-upper arm circumference. It is arguably one of the most vital, life-saving tools in humanitarian medicine.
What is it exactly?
It's not a complex machine. It's literally just a simple, flexible measuring tape, usually color-coded green, yellow, and red. A health worker simply wraps it around the middle of a child's upper arm.
So they don't even need to be able to read a specific numerical measurement. They just look at the color.
That is the beauty of it. Green means healthy. Yellow indicates moderate acute malnutrition. Red indicates severe acute malnutrition.
Wow, that is incredibly simple.
It is incredibly rapid, highly practical, and requires almost zero formal medical training to administer. A single community volunteer can assess hundreds of children in a single day.
And again, this ties directly back to our vulnerability metric, right?
Yes. A child with a red MUAC reading is deeply immunologically compromised. A minor respiratory infection that a healthy child would easily fight off could be instantly fatal to them.
The questionnaire also has a section on retrospective mortality. It asks families to list any recent deaths in the household, the age, the sex, and the cause.
Right.
And the cause codes are shockingly blunt. Number 1 is violence. Number 2 is respiratory tract infection. 3 is diarrhea. 4 is other. It really strips away the clinical detachment and paints a visceral picture of what is actually ending lives in these environments.
It really does. But gathering this data on paper is fraught with friction.
Because paper gets wet, gets lost.
Exactly. The notes point out that paper surveys are easily damaged, slow to aggregate, and prone to human error during data entry.
But transitioning to electronic surveys requires infrastructure, right? Like servers, electricity, internet. And that simply doesn't exist in a war zone or a newly formed refugee camp.
Which brings us to the technological solutions. Because when the infrastructure doesn't exist, the World Health Organization has figured out ways to parachute it in.
The notes detail several systems with very similar acronyms: UWARS, UWARN, and EIOS. Let's start with UWARS, the Early Warning Alert and Response System.
EWARS is essentially a technological marvel born out of absolute necessity. It's a physical kit designed by the WHO to establish digital surveillance in environments that have been wiped off the grid.
The source notes describe the physical kit, and the visual of this is just incredible to me. I picture a complete pop-up public health department packed into a heavy-duty Pelican case.
That's pretty much what it is.
One single UWARS kit is designed to support a population of 500,000 people. Inside this case, you have 60 mobile phones, one laptop, a local server, and a solar generator and charger. It is entirely self-sufficient.
That autonomy is the linchpin of the whole system. You do not need to rely on the local power grid, which is likely destroyed anyway. You take those 60 mobile phones and you distribute them out to primary care workers, community health volunteers, and whatever hospital staff are left, spread across a vast geographical area.
And they are using these phones to input data based on those standardized case definitions we talked about earlier. So no more apple to oranges comparison.
Precisely. The data they input beams back to the local server housed in the laptop. But it's not just a passive database.
Oh, what else does it do?
The software features interactive alert management. It is pre-programmed the threshold levels for various outbreaks. If the number of reported diarrhea cases crosses a specific statistical line, the system automatically flags the central epidemiologist.
Oh, that's smart.
It also uses GIS, geographical information systems, to map the data spatially.
So you can literally look at the laptop screen inside this tent and see a digital map of the camp with red dots appearing in real time where community health workers are reporting symptoms. You are watching the invisible pathogen move through the population.
It's powerful. And that physical UWARS kit is often the backbone used to implement a broader conceptual framework known as EWARN, the Early Warning Alert and Response Network.
UWARN.
Now, the notes make a very critical distinction within EWARN that we need to dissect. The network utilizes two different types of surveillance: event-based and indicator-based.
Okay, let's break down the friction between those two. How do they differ?
Let's start with event-based surveillance.
Mm-hmm.
This is the rapid, messy, real-world intelligence gathering. It pulls information from multiple, highly unstructured sources.
Like what kind of sources?
It might be a rumor from a community leader, a sudden unexplained spike in activity at the local graveyard, or an unusual cluster of symptoms reported by a teacher.
Wow, okay.
It detects potential outbreaks incredibly quickly, and it can be utilized anywhere for any disease, known or unknown.
Right, so event-based is basically listening to the rumor mill. You hear a village is suddenly sick, you have to go event chasing to figure out what's happening. But isn't that prone to massive false alarms?
It is. Because it's based on unstructured, unverified info, it requires intense, careful checking. It is highly sensitive, but not very specific.
Makes sense.
Now contrast that with indicator-based surveillance. This system defines disease trends and risk factors based on highly structured, credible information coming directly from healthcare professionals and laboratories.
So this is the data coming from the doctors and the MUAC tapes.
Yes. It is significantly more accurate and reliable. However, the inherent trade-off is speed.
Why is it slower?
Indicator-based surveillance is often delayed because it requires a functioning health structure to process the lab tests and officially file the reports. And typically, it only identifies known diseases. It only finds what the system is explicitly programmed to look for.
So event-based is fast, catches surprises, but is unreliable. Indicator-based is highly reliable, but it's slow and might miss a novel pathogen. You need both to cover your blind spots.
You have to weave them together. And then the documentation zooms out to a truly modern, cutting-edge tool, EIOS, Epidemic Intelligence from Open Source.
EIOS.
This is a web-based system utilized by the WHO that continuously scans global media, both traditional news outlets and social media platforms, hunting for the earliest occurrences of outbreaks.
Wait, so it's literally scraping the internet for clues, but how does that work without triggering a million false alarms every time allergy season hits and everyone tweets that they have a runny nose?
It relies on highly complex syndromic surveillance algorithms. It isn't just looking for the word cough. It is looking for semantic clusters, unusual geographical densities of specific symptom keywords, or local news reports about, more than 2 people with mysterious hemorrhagic symptoms.
That is wild.
In the digital age, a sudden localized burst of internet chatter about a strange fever can act as an early warning signal days or even weeks before official medical channels can process the lab work and report a trend.
So EOS kind of acts as the ultimate event-based filter.
Exactly. EOS processes this massive ocean of open-source data, filters out the noise, and analyzes it alongside official national system data.
That is mind-blowing. Someone complaining on social media about a weird rash could inadvertently be the first data point in stopping a global pandemic.
It's very possible, yes.
But all right, let's say the system works perfectly. EORS flags a cluster of red dots on the map. The EOR network registers an official alert based on clinical indicators. EOS picks up local chatter. The radar is pinging loudly. What actually happens next?
The transition from passive surveillance to active response is a highly choreographed protocol, dictated by incredibly strict timelines. Let's look at the reporting frequency required by UWARN.
Okay.
If you are alerting about an epidemic-prone disease and the notes explicitly specify, even just rumors of deaths from a disease like cholera or Ebola, you report it immediately.
Drop everything, grab the radio, make the call.
Yes. Once an outbreak has officially been declared and started, the routine reporting shifts to a daily cadence, strictly listing new cases and new deaths.
That makes sense.
But in a general, stabilized humanitarian emergency, routine reporting from the clinics is done on a weekly basis. And here's a fascinating protocol mandated in the texts. That weekly report must include zero reporting.
I wanted to zero in on this, pun intended, because I initially found it confusing.
A lot of people do.
The notes say zero reporting is required to prevent misinterpretation. But why do we care about a report that just says nothing happened today? If a clinic saw 0 cases of measles, isn't filing a report just creating wasted paperwork for an already exhausted staff?
It seems like it, but in reality, it is arguably the most important piece of paperwork filed all week.
Really?
Think back to the fog of war we discussed. In a highly chaotic, dangerous crisis zone, silence does not equate to safety. Silence is highly suspicious.
How so?
If Clinic A reports 10 cases of malaria and Clinic B reports 0 cases, your first analytical thought should not be that Clinic B miraculously cured malaria in their sector.
What should my first thought be?
Your first thought should be, did Clinic B's radio break? Was the clinic physically destroyed by a mudslide or an airstrike? Did the medical staff abandon their posts due to extreme violence? Or did the community lose trust in the clinic and stop bringing their sick children in?
Oh, wow, I completely missed that angle. Silence is a void, not a negative test result.
Exactly.
Yeah.
By heavily mandating a 0 report, the clinic is forced to actively check in. They are explicitly saying, we are physically here, our equipment is working, we are actively looking for the disease, the system is awake, and we have genuinely found 0 cases.
That completely changes it.
It definitively proves the absence of the disease, rather than just representing an ambiguous absence of data.
That makes perfect sense. Okay, so an alert is triggered. What is the timeline for action? The notes state that verification must begin within 24 hours of an alert. That is a massive, incredibly stressful sprint.
It is a phenomenal logistical burden. If an outbreak is subsequently confirmed, there must be an immediate, comprehensive, on-site investigation.
What does that look like?
And the notes detail exactly what that entails. It's not just a quick supervisory visit. You have to establish the true extent of the outbreak by actively hunting down and counting cases. You have to safely collect relevant biological samples, blood, bodily fluids, cerebrospinal fluid, and transport them securely for lab diagnosis or run rapid tests on-site.
And you have to perform what the text calls descriptive epidemiology.
Yes, the detective work.
Which means doing the actual detective work on the ground, mapping out the who, what, and where, determining whether these cases are clustered in time, clustered in a specific physical place, or clustered by person.
Right. Like, are they all drinking from the exact same contaminated well? Did they all attend the same funeral? Are the victims predominantly adult women or young children?
You are building the profile of the pathogen's behavior.
Simultaneously, you must develop and communicate targeted public health messages to the affected community and perform environmental sampling of water and soil where appropriate.
And all of this is supposed to be coordinated by an outbreak control team that, crucially, should be formed and trained in advance of an outbreak. As the saying goes, you do not want to be building the fire department while the house is actively burning down.
That's a perfect analogy. The notes provide a really stark benchmark for evaluating humanitarian emergencies. They state that ideally, within 3 weeks of the emergency occurring, there should be full U-worn development and installation.
3 weeks.
Yes, and the complete procurement of essential medical and lab supplies, including personal protective equipment. You have 3 weeks to stand up a complete functioning disease detection and protection grid from nothing.
It is a monumental, almost impossible logistical feat. But let's say the international community achieves it. They pour in resources, they stabilize the acute emergency, they contain the initial outbreaks. Eventually, the acute crisis phase ends, and you enter what is known as the recovery phase.
Right.
And this is where the narrative of global health often gets incredibly complicated and politically fraught.
It really does.
Which brings us to the complexities of transitioning power. The notes are very clear that you cannot have international NGOs running a sovereign country's health surveillance indefinitely.
No, you can't.
There has to be a transition of power back to national ownership and local oversight to ensure long-term sustainability.
This transition is frequently one of the most difficult, friction-filled phases in global health. During a severe crisis, international actors, the UN, large Western NGOs bring in immense financial resources, highly trained foreign personnel, and top-tier technology like the UWARS kits.
Right.
They essentially build a parallel healthcare system that operates entirely outside of the host nation's Ministry of Health.
Because the host nation's system was either destroyed or was inadequate to handle the surge of refugees.
Correct. But maintaining these parallel systems over the long term is deeply detrimental. If the UN is collecting vast amounts of health data completely separately from the host nation never builds its own capacity.
They stay dependent.
Exactly. The notes urge that international actors must assist national statistics offices to eventually include refugees in their standard national household surveys, rather than conducting parallel, isolated surveys forever.
And there's a really counterintuitive point here that jumped out at me from the reading. The text notes that refugee health services might sometimes be significantly better than the surrounding host community services.
It happens more often than you'd think.
I mean, my default assumption is to picture a refugee camp as the absolute bottom rung of the ladder in terms of resources. But suddenly you have a massive camp backed by millions of dollars in international aid, staffed with top-tier international doctors, utilizing brand-new EWARS servers. Meanwhile, the local town a mile down the road has a chronically underfunded, struggling clinic with no medicine.
If you look closely at the geopolitical dynamics that creates, you can immediately see the socio-political friction. When a struggling host community watches displaced refugees receiving superior free health care, while their own citizens cannot get basic treatments, intense resentment builds.
It can violently destabilize the entire region.
It pits vulnerable people against other vulnerable people. This is exactly why the notes state that care must be equitable, and data collection must cover host community members alongside refugees to accurately compare conditions.
So data isn't just medical in this context.
No, it is a vital tool for equity and diplomacy. If the surveillance data highlights this severe inequity, international funding can be logically adjusted to support and upgrade the host nation's health system as well, rather than just funding the camp in isolation.
The sources also spent a lot of time talking about community engagement, the necessity of training both refugees and host community members to actually collect the data themselves.
Because that is the only way to build trust. The text explicitly warns that community priorities may be vastly different from the priorities of outside medical experts, especially in times of deep conflict.
Give me an example of that.
Well, an international doctor might be solely focused on cholera, while the community is desperate for trauma care or maternal health support. If you do not engage the community and specifically marginalized groups within that community meaningfully in the planning and delivery of these systems, the systems will fail.
How does a lack of engagement cause a tech system to fail, though?
Because the technology relies on human input. If the community fundamentally does not trust the foreign health worker carrying the UWARS phone, they will hide their sick children.
Oh.
They will refuse to report the rumors of a new disease. They will avoid the clinics. Your multi-million-dollar surveillance net breaks because no one is willing to speak into it. Transparency, accountability, and shared cultural values are just as vital to epidemic intelligence as the solar panels running the server.
Wow. So we've looked at the hyper-local level, the community health worker navigating trust with the ORAB UAC tape in a tent. And we've looked at the regional level, the complex diplomacy of national health ministries taking back control from NGOs. Now, for the final section of our notes, we have to zoom all the way out to the macro global level because pathogens, famously, do not respect sovereign borders.
No, they do not.
But
A virus does not need a passport, and that biological reality is why the International Health Regulations, commonly known as the IHR 2005, exist.
yeah, IHR 2005.
This is the overarching legally binding framework that defines the mutual obligations of 196 participating countries in managing public health risks, events, and emergencies that have the potential to cross international borders.
It is quite literally a global treaty on disease control. The notes summarize that all 196 countries are legally obligated to build the capacity to do four things: detect, assess, report, and respond. And the ultimate mechanism, the biggest alarm bell in this entire framework, is the PHEIC. PHEIC, the Public Health Emergency of International Concern.
A PHEIC is the loudest, most consequential alarm the global health system possesses. When an event of concern happens within a country's borders, that country has a strict legal obligation under the IHR to assess the public health risk within a 48-hour window.
48 hours is fast.
It is. If it meets certain criteria, they must officially report it to the World Health Organization within 24 hours of that assessment.
I want to look at how they actually make that determination, because doing that in 48 hours seems wild. The notes say a PHEIC can be declared if an event meets at least two of the following four criteria questions. Is the public health impact serious? Is the event unusual or unexpected? Is there a significant risk of international spread? And is there a significant risk of international travel or trade restrictions?
Right. Two out of those four triggers the global response protocol. And evaluating those criteria is a complex debate.
I bet.
Assessing the risk of international travel or trade restrictions involves evaluating economic impacts alongside the biological threat. It requires balancing the fear of the disease against the devastating economic consequences of shutting down global shipping lanes or grounding international flights.
But there are also certain diseases mentioned in the text that bypass this four-question debate entirely. The notes divide them into always notifiable and potentially notifiable.
Yes, certain pathogens are considered such an extreme inherent threat to global security that a single case automatically triggers the reporting mandate.
The always notifiable list honestly gave me a bit of a chill just reading the names on the page. Smallpox, wild-type polio, human influenza of a new subtype, SARS.
Yeah, they are terrifying.
Imagine being a health official in a regional lab, looking at a sample under a microscope and realizing you are looking at a new strain of SARS, or, God forbid, smallpox. You don't debate the four criteria. You are legally obligated to pick up the phone to Geneva immediately.
Because those four specific diseases possess a terrifying, unique combination of high transmissibility, high mortality, and global novelty. The potentially notifiable list is also severe, but slightly different in its global threat profile. Cholera, pneumonic plague, yellow fever, viral hemorrhagic fevers like Ebola, and West Nile fever.
So what happens with those?
An outbreak of these requires rapid assessment based on those four criteria we discussed to determine if it constitutes a PHEIC.
But as pristine and logical as this global legal framework looks on paper, the source material ends with a very sobering section on criticisms, and it specifically points to the COVID-19 pandemic as the ultimate catastrophic stress test of the IHR 2005.
It does. The academic text notes that the pandemic highlighted severe systemic flaws in the actual application of the IHR. Primarily, it showed that very few member states actually possessed the adequate preparedness and timeliness required by the treaty, despite their legal obligations to build those capacities over the last 2 decades.
And it points heavily to extreme global inequality as the root cause.
The notes highlight the profound structural inequality in resources, laboratory capacity, and economic power between high-income and lower-income countries. The IHR legally demands that every country detects and responds to outbreaks rapidly.
Right.
But signing a treaty doesn't magically provide a lower-income country with the advanced laboratories, the trained epidemiologists, or the massive funding required to do so.
It's an unfunded mandate on a global scale.
The source material argues that the responsibilities, benefits, and burdens of global health surveillance need to be much more carefully and equitably balanced. The academic consensus presented here is that a system of mutual obligation only works if there is mutual capacity. If one country cannot afford to detect a novel virus, the entire 196-country network is compromised.
So bringing this all together, We started this deep dive looking at a deeply fractured landscape. No roads, no power, just vulnerable people in muddy waters. And we've tracked the incredible journey of a single data point.
It's an amazing journey.
It is. How a mother telling a community worker her child has a fever, or a volunteer wrapping a yellow MUAC tape around an arm gets fed into a solar-powered Pelican case. How it becomes a red dot on a digital map, verified by a lab, scaled up to an outbreak investigation, and ultimately how it feeds into a legally binding global network that literally determines whether the borders of 196 nations stay open or shut. It is an immense, largely invisible architecture of human labor and ingenuity that operates every single day to try and keep us all safe.
It is a remarkable, if imperfect, achievement of global cooperation. But looking closely at the mechanics of these tools, particularly the digital ones, raises a really important question about the future of this architecture.
What's that?
We spent time unpacking EIS, the system that relies on open-source media, scraping social media platforms and local news to detect the earliest whispers of an outbreak. But what happens as the internet becomes increasingly fragmented and localized?
What do you mean?
Well, if authoritarian regimes choose to tightly censor their domestic internet, shutting down localized chatter about a mysterious illness, or if shifting global privacy laws severely restrict the ability of health organizations to mine social media data, how will these predictive algorithms function? As we rely more and more on digital intelligence to act as our early warning radar, can global health surveillance survive an era of digital blackouts and firewalls?
That is a deeply chilling thought to leave on. The weather radar is only as good as the signal it's allowed to receive. If the signal is blocked, we are back to flying blind. Thank you so much for joining us on this deep dive into the hidden machinery of global health. Keep looking closely at the systems around you and keep questioning how the invisible dots connect. We'll catch you next time.